All right. Good morning, everybody, and thank you, Dr. Levy, for being here this morning. So let me just minimize this here. So, oh, there we go. Great. So I'm Jason Larita. I'm one of the chief residents, and the title of my study is Effect of Standing Radiographs on the Management of Vertebral Fractures. Special thanks to all of my co-authors here, especially Jason and Kira, who did a lot of the grunt work for this study. So by way of introduction, vertebral fractures are a very common consult question that we get at OHSU. Vertebral fractures affect 2 to 6% of blunt trauma patients in national registries. And this can result from all kinds of different trauma, high energy, low energy trauma. These fractures can be chronic or degenerative, and they can be pathologic. But regardless of how they happen, of primary importance is the fracture stable or not? Does it need fixation or not? And if these fractures appear stable or non-operative or indeterminate on imaging, then stability on the CT imaging, the stability is then interrogated with standing radiographs. So standing radiographs after a CT scan identifies a fracture is a practice with wide use but very little validation in the literature. The primary source of this strategy is from a study by Mehta in 2004. And this was a small prospective study of 28 patients where they looked at weight-bearing x-rays of vertebral fractures compared to the supine x-rays for the same fracture. And when they looked at these patients, when they got them up, they found that with weight-bearing, they had a mean increase of 7 degrees of kyphosis through the fracture with weight-bearing. And in this cohort, 7 of 28 patients converted to surgery based on this finding. So a fracture that initially looked stable or inconclusive was then deemed to be unstable. This study was done prior to the publication of the TLIX score, which was the next important development in the treatment of these fractures. This was Lee 2005, Thoracolumbar Injury and Classification Score, A New Paradigm was the title of the paper. So prior to this paper, there was no widespread use of thoracolumbar classification system to predict how to treat these fractures. And the factors that were used in this algorithm were chosen by a survey of worldwide experts. And this is on the right here what the TLIX score is. And in their paper, they say, although this is a systematic approach to determine injury severity, it does not account for many factors that determine course, such as comorbidities, other injuries, or excessive kyphosis. Since this paper was published, it's been validated multiple times in multiple studies with both good intra and inter-rater reliability, and the treatment recommendations have seemed to be valid. Based on the score here, the TLIX score in the top box, you get a score in the bottom box that guides treatment, which is the point of any good classification system. And for a TLIX score of 0 to 3, the recommendation is that these patients don't need surgery, they'll heal on their own. For a score of 5 or more, they're operative and they need stabilization. And if they have a score of 4, it's non-operative or operative, it's surgeon's choice, it's indeterminate. And of course, a lot of patients fall into this score. The TLIX score can be scored on a CT, however, and all of our patients, when they roll into the trauma bay, have a CT. They don't need radiographs to get this score. So this begs the question, how much added diagnostic value are we getting from these standing radiographs? Why are we getting all these standing radiographs? And this is sort of what prompted the study for me. I saw all these standing radiographs happening, and I never saw any change in treatment plan from them, anecdotally. So that's why I did this study. So my null hypothesis was that standing radiographs have no effect on the course of treatment. The experimental hypothesis is that the standing radiographs do lead to a change in course of treatment in these patients. The significance of this study, as I mentioned, standing x-rays are very widely used, but there are not a lot of studies that look at should we be using them, and are they effective in changing our treatment plan. If the null hypothesis in this study is accepted, there are a lot of potential cost and radiation savings if we're not doing all of these standing x-rays. And if the null hypothesis is rejected, then we're validating a standard of care, and it would be one of few papers to do that. So the methods for my study, this was a retrospective chart review, and we looked at all consults to the OHSU spine service in a 5-year period. We then screened all of these consults by CPT code to see who got a standing thoracolumbar radiograph. We then manually screened all of these patients for a diagnosis of thoracolumbar fracture, and we validated our review with a manual audit from our internal consult list. The inclusion criteria for our study was any patient that received a CT spine followed by upright thoracolumbar radiographs. It had to be over age 17, and we excluded patients who had neurological deficits, who had pathologic fractures, or who couldn't have surgery for medical reasons as confounding factors. We then went through all of these patients and assessed the imaging for what was fractured, where was the fracture, the angulation on the lateral image, and the use of TLSO brace. We noticed as we started the study that some of the x-rays had a TLSO in them and some of them didn't. So we recorded all of that. We then assessed the follow-up notes when they are after their discharge and they're in clinic for any delayed change in the treatment plan. So we looked at their x-rays in clinic for any progression of kyphosis through that fracture, and also read the notes to see if they had a change in plan and they had late surgery. We then compared the patients that had a change of course versus no change in course as a result of standing x-rays. So the primary outcome from my study was change from non-operative to operative management based on these upright radiographs. And then we also looked at several secondary outcomes, including the degrees of kyphosis through the fracture on the upright radiograph, the progression or delta in degrees of kyphosis from the CT scan to the first upright radiograph, and then the progression from the CT to their endpoint x-ray. And their endpoint x-ray was the last clinic follow-up for the non-op patients or conversion to surgery for the operative patients. And here's our flow chart for how the study unfolded. We had 75 patients who met our inclusion and exclusion criteria. The average follow-up for this group was 15 weeks. And as far as results for the primary outcome, we found that 6.6% of patients had a change to surgery based on the upright radiographs during their index admission. That's the 5 patients all the way on the right in this figure. And then a further 2.7% of patients had a change to surgery based on upright x-rays as outpatients. So they were discharged from the hospital, they were followed in clinic, and then some point down the road, they decided that those patients indeed were unstable and needed surgery. So based on this result, I would reject our null hypothesis and say that in this series, upright radiographs did lead to a change in management of vertebral fractures 9.3% of the time. The secondary outcomes were actually, I think, more interesting in this study. So looking here at the absolute degrees of kyphosis, in the first group on the left, I'm comparing the non-operative and the operative group as far as what was their degrees of kyphosis through the fracture on the CT scan. The middle group is the degrees of kyphosis on their first standing x-ray. And the last group is at their endpoint, what was their degrees of kyphosis. And of note, there was no significant difference between the operative and non-operative groups in terms of the absolute degrees of kyphosis at any of these 3 time points. There was a significant increase in kyphosis within the operative group between the CT scan and the first x-ray, as one would expect. So they had their CT scan, they had their standing x-ray, and the absolute degrees of kyphosis was so high that they decided to do surgery. So that's an unexpected result, but that wasn't really one of our outcomes that we were following. It's more of an incidental finding. And this is what I just said. The most interesting finding, I think, here was the average progression of kyphosis from their CT scan to their first standing x-ray and to their endpoint x-ray, and that's graphed here on the right. And as I mentioned, the endpoint x-ray was either the delta kyphosis at their last follow-up for the non-op group or their delta kyphosis before their conversion to surgery. And what we found is that the mean change in kyphosis for the first standing x-ray was 4.1 degrees for the non-operative group and 11.1 degrees for the operative group, and this was significantly different. That's the grouping here on the left side of the figure. And I think this was the most interesting finding of our study. So this was showing that while the degrees of kyphosis, the absolute degrees of kyphosis was not different between the two groups, the progression, the difference from their CT scan to their first standing X-ray was significantly larger in the operative group. This was in keeping with that meta study that I cited earlier, which had an average progression of kyphosis of 7 degrees for patients from their supine to their standing X-ray, which obviously our CT was supine as well. And then looking at the second grouping here on the right, the endpoint X-ray, both groups had a progression of about 3 degrees of additional kyphosis from their first X-ray to their last X-ray, and this was not significantly different between the two groups. By way of discussion then, in our cohort, the primary outcome showed that 7 of 75 patients, or 9.3%, had a change to operative management after their upright X-rays. Now, of course, after does not mean as a result of. But then we went through and did a chart biopsy of all these patients and found that 5 of the 7 patients who converted to surgery, the surgeon explicitly cited the change in kyphosis on their upright X-rays as the reason for surgery. So there is no threshold for conversion in the literature, meaning there's no number that says, well, if your fracture collapses this much, then you must do surgery. It is a multifactorial decision, and that's kind of what makes this study complicated, that we're trying to look at a decision-making process of the surgeon of these patients who are complicated. One thing of note was that our spine consults are handled here at OHSU by both the orthopedic and the neurological surgery service. And of the 7 patients who converted to surgery, 6 of them were on the neurosurgery service. Which is maybe why I had the impression that the upright X-rays don't tend to change practice very much, because for the orthopedic side, it didn't very much. But on the neurosurgery service side, that was more common. And then, of course, interestingly, we'd want to know how these patients correlate in terms of their TLIX scores. And as I said, TLIX scores of 5 or above are immediately operative, and if they're 3 or below, they're non-operative generally. But in our cohort of patients who transferred to the surgery treatment side, these are their TLIX scores. 3 of them had TLIX scores of 4, which is indeterminate, and 4 of them had TLIX scores below 4, which suggests that in our small cohort, all of these operative patients might have reasonably gone down the non-operative pathway based on the TLIX score alone, but these patients who had upright X-rays went from non-operative to operative treatment, which I thought was interesting. And then a quick word on TLSO use. So as I mentioned, we were tracking this as a secondary outcome in our study. In the non-operative group, 31 of 68 patients had upright in and out of their TLSO, meaning that we had X-rays showing that their first X-ray was in TLSO, and then somewhere along their follow-up, they came out of their TLSO and had upright X-rays. And the average progression of kyphosis in this group from their last TLSO X-ray to their first non-TLSO X-ray was 3.6 degrees. Of interest, in the operative group, all of them had their first standing X-ray in the TLSO, which to me suggests that already there must have been a higher suspicion from these surgeons that there might be some instability because they all had X-rays in a TLSO. Then 5 of the 7 patients who converted to surgery, it was based on their first upright X-ray in their TLSO. So they collapsed enough in their TLSO that the surgeon called it. And then 2 of 7 patients who had a delayed conversion to surgery. This was really interesting. So these patients were seen in the hospital, had upright X-rays in the hospital in their TLSO, and were discharged. Then in these 2 patients, their first radiograph in a TLSO showed a collapse of 0 and 0.5 degrees. So they really didn't move in their TLSO. But as outpatients, they had X-rays out of a TLSO, and their collapses were 24.4 and 8.5 degrees respectively, which to me suggests that the TLSO may have been hiding occult instability that was not noticed while they were still in patients. So the conclusions from my study is that there were a significant number of patients, 9.3%, who converted to surgery based on upright weight-bearing radiographs. There was a significant difference in the change in kyphosis on first staining radiograph between the non-operative and operative groups. And TLSO use was very variable in the study, but may have contributed to a delayed conversion to surgery in 2 of the 75 patients. That is my study. These are my references. Thank you very much.
Okay. Congratulations, Dr. Laurita. Dr. Levy, you have the floor.
Okay, great. So just a quick, for a great study. I'm not a spine surgeon, but there's some important things here. And, I think this is gonna get published. Couple things, just style points, okay?
Sure.
For PowerPoints, if I have to do this to see the slides, even with my glasses, it's too small, the wording, and too much wording on the slide. So it's okay to have more slides, but I would have it less busy, especially in the words, and have them bigger font. Okay.
Sure.
Okay, so let's go over the paper. Okay. See that? There's a lot of notes.
Yeah.
It's good though. Okay, you ready? Mark this stuff down because I think it'll be helpful.
I will.
Okay. All right. So in the paper, there's no abstract. So you need to have an abstract.
Yes.
And in the introduction, the last thing you want in an introduction is the purpose, okay? Which then leads into the methods. So you have the purpose, but it doesn't really state the purpose of the paper is or the aim of the purpose is. So you really need that. And you want to outline the clinical significance of your study before you say the purpose. So it's therefore the purpose of our study is, not the purpose of our study and then the clinical significance. That's totally backwards. Okay. Now in the purpose, I loved your conclusion slide because I had actually written down one, I don't know, is it backwards view? Or do you see it? You see it?
Too small, I can't see it.
We can see it. Yeah.
Okay. So number one for me in the purpose was, do standing x-rays change operative decision making? That's number one. Number two, I wrote, does TLSO matter? That's a secondary purpose. And a third purpose is there a kyphotic angle that changes decision making? Okay, so those should be the aims of your study because that's what you studied, but it doesn't say it anywhere. Okay, it does in the conclusion. In fact, the conclusion is perfect. So through the whole study, you should clearly state what you're studying. So the purpose of our study is to assess blah 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 blah. Secondary outcomes are blah 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 blah, or a secondary purpose is blah blah blah, and then you follow that through your methods section on how you accomplish those tasks. Then your results follow those in order, and then your discussion follows those in order. And your discussion, you started with the main finding of the study. That's why I gave you a clap there, because that's really important. Okay. Sorry, did someone say something? No. Okay. Now in the methods section, why did you exclude the patients due to the fact that they couldn't have surgery? For me, this study is about decision-making for surgery. So I don't think those patients should be excluded, because you can make a decision whether they're excluded. The fact that they are too sick to have surgery is a whole other thing. But why lose them? Why lose them? Keep them in there, because it's all just about decision-making on whether or not they meet operative criteria. Okay?
Sure.
Discussion good. Yeah, so I talked about kyphosis, already did that. Did you? Oh, so in this, there was somewhere in the paper where it said you recommend if it's over 10 degrees for operative decision making, right? To me, that's really strong. Unless you looked at 0, 5, 10, 15, 20, 25 and said, okay, the indication for surgery, is over that. This is basically just, in a way, random surgical decision making, where the surgeons have said, okay, that looks big enough, I'm going to operate on it.
Right.
So I don't think you can really make a conclusion that we recommend over 10 degrees. It's not what you studied. You
Mhm.
just want to report what you study. Let people make their own inference of what degree of kyphosis is going to trigger them to do the operation.
Sure.
There in the paper, there's no strengths or limitations section, so that needs to be in there.
Sure.
And in the conclusion, your slide was perfect, but the paper didn't have that. Let me look at the. Yeah, you didn't. Hang on, let me just look. Yeah, the conclusion, I would get rid of your conclusion and just put the conclusion that you had in that PowerPoint.
Got it.
Okay, because
Yeah.
that is like was perfect for me.
Mhm.
You don't want to add into conclusions what you didn't study, which is
Sure.
we suggest there's a significant difference. Well, it's not you suggest, you found. So just take what's in this paper out and put what you have in the conclusion in. Okay.
Can do. Yep.
Okay, that was pretty much it.
Great.
Incidental, but oh yeah, you said incidental finding, but then you put in the conclusion. Okay, we already talked about. The last thing is in your results on your PowerPoint, you talked about your null hypothesis and you said that's in keeping with meta study.
Mhm.
Well, results are only results. Our results are boom. The rejection of a null hypothesis or how it's in keeping with other patients, or papers, that's discussion section. That's
Sure.
how your findings are different or the same of other people's papers.
Yeah.
Okay. All right, that's it.
Great. Thank you so
Thanks,
much,
Scotty.
Dr. Levy.
I
I
mean,
really
this is-
appreciate it.
Yeah, this is the type of stuff that changes clinical practice.
Yeah.
Because if I'm a spine surgeon, I'm thinking, I'm not doing standing upright x-rays with a TLSO on.
Yep.
I had one
Great.
quick add-on
Yeah.
before we go. I don't want to get us too far behind, but I was just interested also in hearing about how age and pain would affect, because it does seem kind of just like this random, decision making, like, oh, we changed our mind, but osteoporotic bone is going to have a lot more collapse and deformity with weight bearing compared to young trauma bone. And so most of these people don't have DEXAs, but if you use age as a predictor of osteoporosis, would there be a significant change in, kyphotic progression with either treatment, operative or non-operative? Can you predict that with age as a predictor? And does that correlate with pain? And was that part of the decision making if patients came back and they were dissatisfied due to pain? So just some thoughts.
Yeah. No, that's a great question. And I think the answer is that yes, part of the decision making certainly was pain. But I think our cohort was too small to try to control for that. But that was definitely an important question that is not answered by the study.
Great work,
Great.
Jason.
Thank you very much.
Yeah, thank you. Thank you so much.